To close our luncheon program today, let's turn our focus to prioritizing the patient voice in healthcare. First, you'll hear 3 different personal stories on that theme. Then, our guests will explore the subject further in a panel discussion led by our very own U.S. News Deputy Editor, Lindsay Lyon. We'll begin with Tiffany Christensen, Vice President of Experience Innovation at the Barrel Institute. She approaches her work from the perspective of a lifelong patient and professional patient advocate, and has worked alongside patients in major medical institutions and the North Carolina Hospital Association. She has authored 3 books exploring advocacy and partnership strategies in healthcare. Then you'll hear from Liz Salmi, punk rock drummer turned cancer patient. Salmi is now Senior Strategist for Outreach and Communication for Open Notes, a research project and movement based out of Beth Israel Deaconess Medical Center. Liz serves on the board of directors for the National Brain Tumor Society and is a patient reviewer for the Patient-Centered Outcomes Research Institute. Then we'll hear from Dr. Jeff Goldenberg and Naomi Kurtner, the founders of Talia's Voice, Projects for Patient Safety. Naomi serves as a patient advocate and sits on multiple committees at the Collaborative for Accountability and Improvement. Jeff was a family physician for nearly 3 decades until a few years ago, after their lives forever changed, as you'll hear about shortly.
Good afternoon. I was diagnosed when I was 6 months old with what I consider to be the gift of cystic fibrosis. While I had a relatively normal childhood, by the time I was in my late teens, early 20s, I was living a life of oxygen tanks and IV therapy and all kinds of medications and ER visits and hospitalizations. By the time I was 26, I was devastatingly ill, and it was time for a double lung transplant. When I received the call for my transplant lungs, I was 18% of lung capacity. I was 87 pounds. The doctors were estimating I had somewhere around 6 more months to live, and I had been waiting for 5 years. This is a picture of me in the ICU after my double lung transplant. And I always like to give people the opportunity to do a little compare and contrast, because I think no matter who we are, when we walk into a room and we see this person, it's very difficult to simultaneously see this person. Would you agree? Would you also believe me when I tell you that I was absolutely, thank you. I only have 3 minutes, guys, but thank you. So I was absolutely aware of what was going on around me and to me in this moment. In fact, I remember it very clearly. I remember that my sister took a picture of me. Her husband turned to her and said, "I can't believe you just took a picture of her. That is really inappropriate." And then she turned to her and said, "Well, she told me to, Paul, so what am I supposed to do?" And I'm thinking, that's right, Jill, you tell him. So not only was I listening to what was going on around me, I was actually participating within myself. And there was no way that anybody could know that. My eyes didn't flutter, my head didn't move. There was no external indication that I was even awake. And there were people who took care of me during that time that understood that, and people who took care of me who didn't. The people who didn't understand that were the folks who would talk over me as if I were an object. They would do things to me without narrating their care first. But the people who did understand that, they were the ones who would come in, they would touch me, they would talk directly to me, they would give me status updates on my health. Their behavior showed me that they understood that that external body does not necessarily reflect the internal life. And what an amazing thing to be able to keep that in the front of their mind day after day, taking care of patients who look like I did. So after I was extubated, I was on the ventilator for 4 days, and after I was extubated, I was in the hospital for 3 weeks. I then went home and enjoyed the greatest lung function of my life. It was extraordinary. Unfortunately, however, it did not last as long as we had all hoped, because 2 years and 2 months after my double lung transplant, my lung function started to drop. I was diagnosed with chronic rejection. Within about 2 years, my lung function dropped to roughly 10% of capacity. I was 73 pounds. The doctors were estimating that I had somewhere around 6 more months to live. And at the very 11th hour, the physicians at my hospital decided they were going to try to give me a second double lung transplant. That was over 15 years ago. So I'm a very lucky individual. Years after my second double lung transplant, I was working at an academic medical center as a patient advocate, and I was standing at the bedside of a patient in ICU, and the nurse beside me said to the family, "Oh, your loved one is asleep, they can't hear you." And in addition to wanting to cry and scream, "No, no, no, that patient might be listening, please do listen, talk to them," I also thought to myself, where did that nurse get that information? Who told her what it was like to be intubated? I am here today to talk about listening. As a person who has a lived experience, I like to say, I may not be able to tell you how to intubate a patient, but I am here to talk about what it's like to be an intubated patient. And for some reason in healthcare today, the reality is that we still resist listening to the lived experiences of our patients. And I don't really know why, because it allows us to be more efficient, it allows us to improve our outcomes, and it certainly improves our experiences. So I look forward to digging deeper into this conversation during the panel today, but for now, I just want to say thank you for listening.
In 2008, a week after my 29th birthday, I suffered a grand mal seizure. I landed in the ER and a scan showed I had a mass in my brain. And after a 9-hour surgery, I learned I have an astrocytoma, which is a slow-growing but malignant brain tumor. 6 months later, this tumor grew back. And it sent me into a whirlwind of treatments over the next 2 years, including a second surgery, relearning how to walk and balance, and 24 months of chemotherapy. There's no right way to respond to a cancer diagnosis, but I leaned in. I took copious notes, asked questions, and used my hospital's online portal to schedule follow-up visits, order prescription refills, and look at my lab results. My husband, Brett, came with me to every appointment. And together, we'd consult Dr. Google. People in healthcare talk about patient engagement. You can't find anyone more engaged than us. 8 years after my diagnosis, something changed. Brett was offered a great new job, but it meant we had to switch health plans and hospitals and pick a whole new healthcare team and do a medical records request so my new care team would have my complete healthcare history. We all have the legal right to request and receive copies of our medical records. But I can tell you, this process takes time and effort, and costs can be involved. $725 was the price tag for a hard copy of my record. So I opted for the less expensive digital copy, and this eye-popping number of pages was about $45 on a DVD. Yet within this number of pages was stuff I had never seen before, stuff I didn't know even existed. My doctor's notes. I now know our doctor's notes are the most important part of our medical records. Sure, these pages contain things like lab results, emails with my doctor, but this stuff I had never seen before. I could Google my condition, but I never knew what my own doctors were writing about me. And because I had been taking meticulous time, date-stamped notes of my own, I could compare my notes to my doctor's notes, which meant that for every question I had written down, there was a corresponding clarification in my doctor's notes. I couldn't believe it took me 8 years to stumble across this information. Today, I get my care at 2 academic medical centers. Both have achieved most wired designations for their use of technology, and both are listed among the best hospitals by our friends here at US News and World Report. However, despite a growing body of evidence that when patients have access to their doctor's notes, we better understand our care and trust our doctors more, neither of my institutions has adopted information transparency practices to make it easier for patients to access our full medical records. I know my new doctors are writing about me. They spend a lot of time in front of their computers. But if I want to read and benefit from what they are writing, I must jump through hoops, make multiple visits to the hospital, fill out piles of paperwork, stand in lines, wait up to 30 days for a response, find a fax machine, and the responsibility lands on me to provide education to most healthcare workers that HIPAA is not in place to protect me from my own health information. Today, without ready access to my doctor's notes, I am left to wonder, is this doctor really listening to me? Did she capture in writing the parts of the visit I already forgot? Are there errors? When Brett and I disagree on what the doctor said, who will be the tiebreaker? I still have brain cancer. I'm about 4 years beyond the average survival time for my diagnosis, and there's a very real possibility that my brain cancer will turn into a more aggressive version of the disease. To me, patient engagement means taking my anti-seizure medications on time, getting regular brain MRIs, and going to follow-up visits with my neuro-oncologist. But patient engagement also means having access to all of my information, including my doctor's notes, as soon as I need it, in the most painless way possible. The only thing standing in my way are the information gatekeepers at my own hospitals. Thank you.
Sparkly-eyed and luminous, our daughter Talia was a think-outside-the-box artist, a fearless athlete, the fun sister, who was easy with big, messy feelings. She was known, ironically in the end, as the consummate listener, a safe harbor for everyone. Surgeries like the spinal fusion Talia had in 2014 to treat instability in her neck naturally come with risks. But the risks 23-year-old Talia signed off on were unrelated to those that killed her.
Talia's doctors were not aware they had dislocated her jaw in the operating room, most likely when the anesthesiologist intubated her. After surgery, Talia's jaw was locked, so her mouth could barely open. Her neck was now fused, so it wouldn't bend. Lying flat on her back and frightened, Talia was struggling to breathe due to a swollen airway that had her sounding like Darth Vader. As a doctor, I knew that she was in grave danger. Talia would be nearly impossible to intubate if her airway closed. She could die. I alerted everyone to this brewing emergency, and so did Talia.
In the early morning hours after surgery, during rounds we were not told were happening, Talia asked her neurosurgeon why she still couldn't breathe and what could be done to fix her jaw. Rather than examine her or call in a specialist, he told her that nothing he had done could have caused her jaw troubles, and she'd just have to see another doctor upon discharge. As for her difficulty breathing, he dismissed it entirely and wrote orders to transfer her out of the ICU. Then he left to catch a plane without ever speaking to Talia's ICU doctors.
Talia's words still haunt me. "I wish you'd been here, Papa. They wouldn't listen to me." And they didn't listen to me either. After 25 years of working to keep my patients alive, I would watch my daughter die of the exact preventable causes I repeatedly urged her caregivers to address.
How could Talia have a team of physicians who didn't communicate with each other about her care? And what's going on in hospitals when non-physician staff are afraid to speak up? Like Talia's nurse, who, caught between Talia's needs and the doctor's plans, never questioned the plans and quit advocating for Talia. Or the speech pathologist, the one person who examined Talia's airway, who detailed Talia's precarious breathing issues in the chart, yet never told anybody about Talia's critical situation.
We asked every provider for help. Each refused to listen or believe. There were at least 11 missed opportunities to save Talia's life.
Imagine Talia's terror when, 22 hours after she emerged from surgery, her airway did close. She looked back and forth from me to Jeff, frantic. Her eyes bulged. Then she thrashed like a person being strangled. In her last conscious moments, Talia was bursting with the need for air, knowing she was suffocating, aware she had been abandoned, that she was going to die. And then she went still.
It took 10 minutes for the code team to assemble, 20 to do a crike, a procedure to open her airway that I kept shouting for now, and had been urging everyone to be ready to perform from the moment Talia's breathing troubles began. But I was powerless to get them to act, and I knew what each subsequent minute without oxygen meant. Cerebral palsy, organic brain syndrome, irreparable brain damage, brain death. Waves of nausea just kept washing over me. By the time an anesthesiologist finally arrived and performed the crike, Talia lay comatose in a permanent vegetative state. For 9 long days, we had to be perfectly polite to those providers to ensure our girl received optimal care. Then, with 0 chance of recovery, we pulled life support, staying by Talia's side for 37 grueling hours until she died. 5 years later, we are still reeling from this nightmare.
Should we even call what happened to Talia errors? Her providers made the choice not to listen. Providers everywhere do this all the time, under pressure to get to the OR or on with their day, to be ever more efficient. This pervasive culture of not listening is rampant. It's scary when you think that every one of us will be a patient one day. Yet, the capacity to listen always exists, and each of you is in a position to make it happen.
Thank you for sharing your powerful stories with us. So each of you is working to inspire culture change in different ways. Jeff, let's start with you. Despite the fact that you're a doctor and you're both highly savvy patient advocates, you still felt powerless to act at critical moments during Talia's care. What has this experience taught you?
It reinforces for me, as a doctor, the value of listening in the delivery of care. We know that listening saves lives, and not listening costs Talia hers. We started Talia's Voice, our nonprofit, with a goal of getting healthcare professionals to listen to each patient and stand up for them and advocate on their behalf. when we tell people what we're trying to do through Talia's voice, the inevitable reaction that we get is, oh, that's good, keep doing that. Let me tell you what happened to us. And that's because we all know that listening in medicine, or not listening in medicine, is a problem. And until we can get everybody who's involved in medicine on board with the idea that listening is important, that's not going to change. We need leadership, and it's really leaders who are going to have to lead the change to a culture of listening.
And Lindsay, I think practice makes perfect. Doctors have amazing skills that they've honed through hours of diligent repetition. Unfortunately, one practice they've perfected is the art of not listening. And it is really going to take leadership to shift this paradigm. As Talia's voice, one thing we're trying to do, one goal we have, is to get leaders like all of you to be able to look people like me in the eye. I'm the mama of a dead girl, and say that what happened to Talia cannot and will not happen in your medical institution. I think that.
Thank you for sharing that, Naomi. So Tiffany, you bring a unique perspective. You're a lifelong patient and a 2-time double lung transplant survivor. You've been a patient advocate at a hospital, and now you're with the Barrel Institute, a leading voice on the patient experience. What matters most to patients?
Well, I think there's lots of answers to that question, but very generally speaking, in 2018, we asked that exact question. We did a study, what we called the consumer study, and we found that the top 3 things that patients are asking for are not quite surprising, but very clear, and that is that they want to be listened to, number 1. Number 2, they want to be treated with courtesy and respect, and number 3, they want to be spoken to in a way that they can understand. And really what that all boils down to, I think, is that we've built healthcare on a transactional model. And what patients and families are asking for is to transition that model to a relational model.
Absolutely. And Liz, as a patient, you had this lightning bolt moment when you dove into your medical record and discovered your doctor's notes. Now you're part of this big movement to make healthcare more transparent and communication for patients. So briefly tell us, what is Open Notes and how do patients and providers feel about it?
Sure. So Open Notes, we now see as a movement. It's really a research project based at Beth Israel Deaconess Medical Center, but with research partners around the country. And as a movement, we're urging clinicians and other healthcare professionals to share the notes that they're writing with the patients that they're caring for. And where we're at now, after 10 years of research, there's this really big growing evidence base that when you share the notes with patients, they benefit. They better understand their plan for care. They are more likely to trust their doctors more. They're then going to better remember their plan for care. And this is all technology neutral. We're not talking about a new app to download and plug into the EHR. This is using your existing EHR and push it through to the patient portal. And as for what patients think and what clinicians think, you might not be surprised to know that in early surveys, clinicians get anxious about, oh my gosh, if we share our notes with patients, we're gonna get this increase in workflow, and we're gonna get all these phone calls and emails, and time again, study after study after study, show that does not happen at all. And in fact, after, say, a month of sharing notes, clinicians realize their workload does not increase, and then they calm down about it. Meanwhile, patients love this. They rank Open Notes and having access to the notes as a really important aspect of their patient portal that really gets them the information that they need.
So you're touching a little bit on assumptions, which is a nice segue to our next point. And so assumptions about patients can really run counter to listening and have impacted each of you. So Tiffany, you've observed that this well-meaning movement of empathy in healthcare can sometimes translate to assumptions about what patients feel, experience, and want. Tell us what you mean here. How have assumptions affected you?
Well, I'm always a little nervous to talk about this because I don't ever want anybody to think I'm saying that empathy is a bad thing or that we shouldn't care and have compassion for our patients. But I think that if you look at the definition of empathy, which is to imagine how someone else might be feeling, that is a little bit of a challenging, perhaps dangerous line to be walking when you're talking about patients, because I can assure you that every patient that you speak to, if you say to them, I'm pretty sure I know how you're feeling, they're not gonna agree with you. So for me, it's about why are we talking so much about empathy? We're talking so much about empathy because what patients and families are asking for are, and this is going to be obviously the theme for today, to be heard, to have someone be present with them. Right now, the last study that showed that physicians take about 10 seconds before they interrupt a patient who's trying to tell them why they came in to be seen that day. So literally listening is step one, and then going beyond that to all different layers of listening is what patients really mean, I believe, when they say empathy.
And tell us about your life as a patient with cystic fibrosis and the assumptions that have been made about what that must mean for you.
Well, the easiest example is that when I was dying, I kept coming into clinic with a really bad attitude. And people had the assumption that they felt empathy for the fact that I was 30 years old and I was dying, and they assumed that's why I was cranky. And in reality, I was cranky because I figured, I'm dying. Why am I still having to come here and see you people, right? So without the curiosity to be able to step back and say, you seem out of sorts, Tiffany, is there something going on? We were having these conversations that were coming from two very different mental models, which didn't help either of us.
And you've talked about the gift of cystic fibrosis, whereas others might assume that that's something negative for you.
Exactly, and so the idea that I love my illness and I wouldn't trade it for the world already shows that my perception of my lived experience is going to be different than maybe the patient who's sitting next to me. And again, we go back to this idea of presence, curiosity, and listening.
And Jeff and Naomi, how did assumptions impact Talia's care?
You know, while Talia was in the hospital, I think that she was being viewed as pretty healthy, very anxious young woman who was having a little discomfort from intubation because it had been a long surgery, but she really just didn't know what that was. And their assumptions were such that they couldn't look at her and think, maybe she's saying she can't breathe because she can't breathe. And the last drug she was given before her airway closed was Valium.
Thank you for sharing that. So Liz, your push for greater transparency in healthcare hasn't always been met with open arms. Some of the obstacles you've faced stem from the notion that patients can't handle seeing what their doctors are writing about them. Are those assumptions overblown? You touched on this a little bit
Yeah,
earlier.
I'd say so.
Yeah.
What is written in a clinical note is a record of what happened in the visit. So the patient was there, you were there in the visit. And in my story, I shared how I was able to figure out from context. Sometimes there are big words in there, acronyms, jargon, but that was my visit transcribed into, say, doctor language. And I'm sure some folks may be thinking, not all patients are like you, Liz. And you're right, not all patients are like me. I'm from this country, I'm a native English speaker. There are certain privileges I have that just make reading the notes somewhat easier. However, after 10 years of research, what we assumed might happen around the concept of sharing notes, we thought certain populations might understand their notes more or like their doctors more. We're actually seeing what those who more appreciate having access to their notes are what are considered more vulnerable populations, older folks without easy access to the internet, people with lower levels of education, poorer health, non-English speakers. Those folks who might even distrust the healthcare system appreciate the opportunity to be able to pull the curtain aside and see what's really being written about them. And we know even with being a native English speaker, we might at most remember 70% of what actually happened in the doctor's visit, at most. But think about if you're getting bad news in a visit, a cancer diagnosis. Maybe you can remember 30% of that visit. And if English is not your language, who knows how much that message is getting across to you. And we're finding that individuals who can go back and refer to a written document by the doctor about what happened that visit. You can go back and reflect, better remember. And then in some cases, for folks who do not speak English, there's somebody at home, a family member, they then share that note with and can digest it and process it later.
Absolutely. So I want to shift back to this theme of transparency and continue the thread. So Jeff and Naomi, tell me about the aftermath. You say that the not listening continues. How has this informed the work that you're doing with hospitals and health systems?
Go ahead.
The thing that didn't happen after Talia died was an apology. To this day, 5 years later, we've not heard from any of her providers nor the hospital. And I just look at it, I'm a doctor, but I'm a person. In life, if you make a mistake, you mess something up, you say, I'm sorry. You apologize. And I think the providers need to do that. They need to be able to do that. And it is a step that helps patients and families on overcoming the disaster that's happened. And there's some pretty good research showing that it's a good first step for providers who need to overcome the trauma of having inflicted harm on someone.
And Tiffany, can you tell us a little bit about, in contrast, you had a medical error happen.
Yeah, so a year before my first transplant, I was called in for lungs, and they put me under anesthesia. They started the operation, and then on the other end, on the donor end of things, there was a medical error, and they cut I'm very clinical here, they cut the tubing too short on the lungs, and they weren't usable, so they had to close me back up and bring me out of the operating room. And I will say that the number one thing I remember from that experience, in addition to just the devastation of it, was the apology from my surgeon. He was at the bedside when I woke up to tell me exactly what happened, to apologize, and to tell me that he would be with us until we had another opportunity to procure lungs for me. And it was that apology and transparency that allowed us to move forward with trust still intact. If he had done it any other way, I don't think we would have been able to move forward.
So open, honest, transparent
Immediate.
communication, and immediate. So that segues nicely into communication resolution programs and the work that you're promoting.
I think it's interesting how much you learn about the culture of a hospital depending on how they handle harm. And deny and defend is still the predominant response, and we're still really damaged daily, waiting for the hospital to take responsibility. And we're trying to change that by our involvement with communication and resolution programs, or CRPs, which I hope all of you have heard about, and if you haven't, find us afterwards, we'll fill you in. But CRPs are a means of communicating in a straightforward and transparent way. And they also offer support to the patients, families, and providers while a deep investigation into the adverse outcome is being done. I think they really have the potential to change the culture after harm and after adverse outcomes, but interestingly, they also really have the potential to reduce the frequency of those adverse events. If hospitals embrace CRPs, open communication becomes the culture of that hospital, and that in turn reduces the likelihood of medical error.
Thank you. So this paradigm shift that you're promoting not only involves listening to patients, but to staff. Why? Jeff, do you want to take that one?
In the case that we were in, with Talia, the doctors weren't even talking to each other. And certainly the staff felt intimidated, which I think is often the case in a hospital, which is very hierarchical. And
you want me to tell that story?
Yeah, you go ahead and tell that.
Yeah, we were asked to present at a hospital a couple of years ago, and in the Q&A at the end, non-physician staff stood up and relayed this story about a patient that she had, and she couldn't get her medical team to hear her concerns about the patient, and she hadn't known what to do. And in that circumstance, the patient didn't die, but the CEO of the hospital stood up in a room like this and told everybody there that if they ever were in a circumstance where they couldn't make their voice heard or weren't being listened to, that he wanted them to call him immediately. And then on the spot, he gave out his cell number. And that's called leadership. And not because he gave out his personal phone number. It's because by doing so, he communicated to his staff the value he placed on listening.
Exactly, and this freedom to speak up if you feel like something is wrong. Can you talk a little bit more about how that played into Talia's care?
We actually, at one point, Naomi alluded to, there was a speech therapist who had examined Talia, and in the aftermath of all this, we discovered that just an hour or two before her airway closed, she actually documented everything in her chart, including the fact that she couldn't breathe, and she didn't tell anybody about it because of the atmosphere that was there in the hospital. And we also had a nurse that morning when we were trying to have her do some other things, and the doctor had said to her, no, we've already given this medicine, and she literally came back and just said, I'm siding with the doctor, and she didn't feel like she could advocate for us, and that was another lost opportunity for Talia.
And Tiffany, how about the importance of making sure staff's voices are heard?
Well, I can say that as a person who went from being in the bed to being next to the bed, I was shocked at the challenges of working in healthcare. And we all know about the epidemic of burnout right now. And if we don't find pathways for our staff to be heard and also to understand their lived experience, then we cannot improve their experience, which then means we can't improve the patient experience. To think that we would be able to have a culture of safety or a just culture without understanding the lived experience of those that are delivering the care is unreasonable. And to think that people can continue day after day after day to deliver good care if they have a poor experience at work every day is also an unreasonable ask.
And I want to dig a little deeper into this concept of burnout, which is the huge issue we're facing today. How do you respond when people say there's not enough time to do all of these things, to share doctor's notes with patients, to prioritize better communication?
I get mad. I'm a little frustrated with the word time. We have time to do a lot of things that are maybe less necessary. And that's, I don't know if that comes across as harsh, but I think that a lot of it is tied to our finances, what we choose to prioritize. If we choose to prioritize safety, if we choose to prioritize experience, we will find ways to build in FTEs to ensure that we are fully staffed, for example. So for me, I would much rather walk into a modest building that is fully staffed than a beautiful building that the people delivering the care are suffering.
And you've made the point that these types of things, they don't require.
You're right. When we look at the things that patients and families are telling us that they want, I want to be listened to, treated with courtesy and respect, and be spoken to in a way that I can understand. All of those things are budget neutral. So we can start today if our leadership chooses to focus on those things.
And Jeff, you're a physician, and you've referenced research showing that meaningful patient-physician relationships actually reduces burnout. Can you talk a little about that?
I mean, it's an interesting thing. Physicians actually do want to do the right thing. They do want to have a relationship with their patients, and they're also, as a group, disappointed that's not happening and frustrated by not quite knowing how to do it. But there have been some, and that's part of what's leading to the burnout, is that dissatisfaction. They're not getting done what they thought they would as physicians. And there's some interesting research that shows in any workplace that when people are able to have more connection with the people they work with and form relationships, that it actually reduces burnout. And this has been looked at in medical settings. So physicians developing more of a relationship with their patients by listening and communicating, even their colleagues at times, they start to develop relationships that ultimately reduce burnout and reduce medical error, because burnout is also a big contributor to that.
Tiffany, I want you to put on your hospital hat for a second. So you've been on the inside, having worked as a patient advocate for a health system. You talked a little bit about some of the challenges of ensuring that patient voices are heard, but are positive changes being made?
Absolutely. We see more and more, for example, organizations having patient family advisory councils, other methods by which they can hear the voice of patients and families beyond surveys. I would say that we are in the beginning stages of that, however. We're seeing design thinking now really infusing within healthcare systems, which means that we're finding other ways to hear the patient family voice, but also to observe and shadow the patient family experience. So we're seeing there's a lot of progress, but as I mentioned earlier, we're also seeing this continued resistance to really using that type of data to inform our decisions for improvement and financial and so forth. So I think we are in the beginning stages of a great revolution of listening differently, and it's up to leadership to open those doors further to make sure that we can really infuse those methods within our systems to reach every nook and cranny.
And you've had your own epiphany as a patient advocate about what it means to listen better. Can you just share briefly about that?
I'll try. So I remember I was on a unit. I was talking to an oncology patient. I was asking her really smart questions, like when your doctor came in this morning, did he speak to you in a way that you could understand? And she kept answering my questions with things that had nothing to do with the answers or the questions that I was asking. And finally, what I realized is, oh my gosh, here I am, miss. I've been a patient my whole life. And I have now operationalized patient experience to such an extent that I've lost touch with what the true actual experience of being a patient is, which is primarily physical, secondarily or equally so emotional. And so in that moment, she wasn't answering my questions because she didn't care about what I was asking her. So we must always know how we are oriented. Am I oriented in this moment as a person who's listening only for my own self-interest for improvement or doing my job? Or am I also able to listen as a person who understands the true lived experience?
Excellent. So in the time that we have left, we have a room full of healthcare leaders. What is one call to action that each of you would like to leave them with today?
Me again? I think mine is obvious. We have to continue to elevate the human experience in healthcare, and that is in every aspect, so that we can ensure that we increase satisfaction or improve experience, but also to improve outcomes, and really just human beings taking care of human beings and making that the priority.
I would say that the human experience of being a patient has changed so much just over the last 10, 15 years since meaningful use and whatever. And patients are going online looking for health information, to be curious, to advocate for those they love, and they are Googling stuff about their health. That's a sign of patient engagement. And it's something you're not gonna stop. But I don't think you should try to stop that behavior. I think it should be encouraged. And those future Google searches can be informed by a doctor and documented by their clinicians, and then potentially shared in the form of transparency, say through an open note, and just clear, open, transparent communication.
Jeff?
Well, for everybody in the room, I guess first and foremost, I would like you to remember Talia and her story. Listening really does save lives, and not listening can kill. And as healthcare leaders, I think all of you have the potential to change what's happening and embrace the culture of listening and live it yourselves. Your staff will follow, and you all are the ones who are going to have to lead the change to a culture of listening.
Naomi?
I guess I just feel like you really have a moral imperative to lead this culture change, because until you do, harm will keep happening and people like Talia will keep dying.
Thank you all for sharing your experiences with us here today. Please give them a round of applause.